Welcome to the Indian Council of Medical Research Online Prescribing Skills Course 2020 for the Indian medical graduate. I am Dr. Sandhya Kamat and today I will be giving a talk on prescribing for children. After viewing this video, please answer 5 multiple choice questions on this video and give your feedback. You will find these in the assignment section. This module has been prepared by me along with pediatricians Dr. Mukesh Agarwal and Dr. Milind Tullu. This module has been reviewed by Dr. Pooja Gupta from AIIMS, New Delhi. India contributed to more than 16% of the under 5 child deaths in the world in 2018. After deaths due to infectious diseases, pneumonia and diarrhea were the leading causes of deaths in Indian children under 5 years of age. Immunizing children against some of these infectious diseases has the potential to significantly impact these unacceptable childhood deaths. As an Indian medical graduate, you will be looking after the health and well-being of not only adults but also children, and hence you need to be aware of the prevention and treatment of some of the common childhood illnesses. This module focuses on important aspects that you need to remember while immunizing a child against some serious and potentially lethal infections, and practical considerations in the treatment of common illnesses in children, for example, diarrhea, pneumonia and acute febrile illness. The learning objectives for this module are as follows. At the end of the module, the learner shall be able to select the appropriate vaccine from the National Immunization Program for the infant or child, identify the potential minor and serious adverse events that may occur after vaccination, state the do's and don'ts of immunization, prescribe rationally for a child suffering from the following conditions: diarrhea, pneumonia and acute febrile illness, identify the need to refer to a specialist for further investigations and treatment if necessary, and state the general prescribing principles in children. Vaccination is a common reason for consultation in pediatrics. As an Indian medical graduate, you will not only have to vaccinate infants and children, but also counsel the parents about the side effects of vaccines, their management, and following up for the next dose. In this module, we will cover various vaccines in the National Immunization Schedule, adverse reactions to the vaccines, contraindications to the vaccines, immunization errors that you should avoid, and some do's and don'ts of vaccination. For starters, let us briefly review what you have learned earlier. The Government of India under the Universal Immunization Program provides free vaccination against 10 life-threatening diseases. These include tuberculosis, diphtheria, pertussis, tetanus, poliomyelitis, hepatitis B, H. influenzae type B infections, measles, rubella and rotavirus. In addition, the pneumococcal vaccine is in the process of being introduced phase-wise, and the Japanese encephalitis vaccine is available in select endemic districts. According to the National Immunization Schedule, in infants, BCG, hepatitis B and the first dose of oral polio vaccine, that is OPV0, are given at birth. Following this, OPV, rotavirus and the pentavalent vaccine containing DPT, hepatitis B and H. influenzae B are repeated at 6, 10 and 14 weeks. 2 fractional doses of IPV are also given along with these vaccines at 6 and 14 weeks. Measles containing vaccines and the Japanese encephalitis vaccines are administered at 9 months. In children, the OPV booster, first DPT booster, measles containing vaccines and Japanese encephalitis vaccines are administered at 16 to 24 months. The second DPT booster is given at 5 years and tetanus toxoid at 10 years and 16 years. The detailed national immunization schedule is given in the reference material. Before administration of the vaccine, it is important to check the vaccine for expiry, reconstitute wherever required and administer by the specific route and site. These details are available in the national immunization schedule. Remember that the dose of most injectable vaccines is 0.5 ml. Exceptions are BCG, the dose of which is 0.05 ml in infants less than a month old and 0.1 ml in infants greater than a month old. The fractional dose of IPV is 0.1 ml. All vaccines used in the National Immunization Program are safe and the occasional adverse reactions that occur are minor and self-limiting. The common minor reactions to vaccines are local adverse events like pain, swelling and redness, fever, and others like irritability, malaise and systemic symptoms such as loss of appetite, rash, headache and muscle pain. Local adverse reactions, fever and irritability and malaise are commonly seen with DPT. Local adverse reactions are also seen with BCG and less commonly with measles containing vaccines and tetanus. The incidence of these minor adverse reactions to different vaccines is given in the reference material. Sometimes vaccines may give rise to serious adverse reactions. However, these occur rarely and do not cause long-term effects. Examples of serious adverse reactions to vaccines are prolonged crying and seizures, and hypotonic hyporesponsive episode with pertussis, febrile seizures, thrombocytopenia and anaphylaxis with measles containing vaccines, intussusception with rotavirus vaccine, disseminated infection with BCG, and vaccine associated paralytic poliomyelitis with oral polio vaccine. The incidence of serious adverse reactions to different vaccines is given in the reference material. Besides these, anxiety related reactions to vaccines may be observed in children over 5 years of age. Note that these reactions often occur as a result of fear of the pain of the injection rather than the vaccine. After vaccination, you need to advise the parents about managing the common minor reactions and give instructions to seek proper medical care to manage the serious reactions. Local reactions and fever can be managed with paracetamol in the dose of 15 mg per kg every 6 to 8 hourly up to a maximum of 4 doses in 24 hours. Errors during vaccination can also cause adverse reactions. Some common immunization errors are exposing the vaccine or diluent to excessive temperatures due to incorrect transport, storage or handling, using a vaccine after its expiry date, failure to adhere to an indication, route, dose, schedule or contraindication, using an incorrect diluent or injection of a product other than the intended vaccine, using an incorrect sterile technique, employing an inappropriate procedure with a multi-dose vial. Your patients count on you to administer vaccines safely and correctly, so be sure that you do not make any of these preventable errors during vaccination. Moreover, such errors disrupt the benefit of the immunization program. Additional information about the sensitivity of vaccines to heat and the various types of vaccination errors is given in the reference material. Vaccines have very few contraindications. They are contraindicated only if there is a possibility of allergy to the vaccine or its components, and if the child is immunodeficient and cannot be administered live vaccines. Note that the precautions stated in the product insert should not be interpreted as contraindications. Once the vaccine is administered, you need to complete the immunization card by writing down the date for each vaccine, mark the next immunization date on the card for the next dose of each vaccine, and counsel the parents about side effects, when to return for the next dose, and to bring along the immunization card at the next vaccination visit. Remember, the do's of immunization are to determine the infant's age and vaccines for which the infant is eligible, to determine which vaccines the infant has received, and if the infant is eligible for more than one vaccine, give them in the same session but at different injection sites. If there is a delay in starting primary vaccination, immunize the infant while maintaining the recommended dosage intervals, and tell the parent to bring back the infant if his/her condition worsens or the reaction continues for 2 days. The don'ts of immunization are: do not use a diluent other than that provided by the manufacturer, do not reconstitute vaccines until you are ready to immunize, do not use reconstituted vaccine after 6 hours or at the end of the immunization session, do not defer or refuse immunization for minor illnesses. Some of the common reasons for which you should not postpone vaccination have been listed in the reference material. Lastly, do not forget to report the adverse event following immunization. Details about how to report an AEFI is covered in the module on monitoring and reporting of adverse drug reactions. Let us now go to the next part of the module, namely the treatment of common childhood illnesses encountered in India. As mentioned earlier, diarrhea and pneumonia are two common causes of under 5 mortality in India. Diarrhea is defined as the more frequent passage of stools than is normal for the child. It is both preventable and treatable. Severe diarrhea can lead to dehydration and may be life-threatening in young children, especially those who are malnourished and have impaired immunity. You have already learnt about the treatment of adult diarrhea in the module on common gastrointestinal disorders. In this module, we shall look at some of the practical considerations in the treatment of diarrhea in young children. Let us look at the following case scenario of an infant with diarrhea. A 1-year-old female infant Meera is brought to your clinic by her mother. The mother informs you that her daughter has had 8 to 9 episodes of watery stools since today morning. On inquiry, you note that there is no fever, nausea, vomiting or presence of blood in stools, but since morning the child has passed urine only once. On examination, the infant is restless and irritable, she has sunken eyes, the skin pinch goes back slowly, The pulse is 130 per minute, which is higher than normal. Weight of the infant is 8 kg. You note that the infant shows signs of some dehydration. As a treating physician, what prescription will you write for Meera? Your prescription will read as follows: sachet oral rehydration salt, contents of 1 sachet to be emptied into 1 liter of water, to administer a minimum of 600 ml over the first 4 hours, to administer 50 to 100 ml of ORS after each loose stool, to administer extra fluid like rice kanji and buttermilk till the diarrhea stops, syrup zinc sulfate 5 ml to be administered once daily orally for 14 days. In addition, you will instruct the parent to return immediately if there is worsening of diarrhea or after 5 days if there is no improvement. The following aspects need to be kept in mind while treating diarrhea in children. WHO classifies degree of dehydration as no dehydration, some dehydration and severe dehydration. Reduced urine output is one of the earliest important indicators of dehydration. ORS is the mainstay of treatment for no dehydration or some dehydration in children. Supplement zinc in all cases of acute diarrhea. Do not prescribe antimotility agents. Do not prescribe antibiotics as viral diarrheas are common in children, and refer the child to a health facility if there are signs of severe dehydration. Referral is needed if any two of these dangerous signs of severe dehydration are present: lethargy or unconsciousness, sunken eyes, inability to drink or drinking poorly, the child vomits everything, the skin pinch goes back very slowly, there is presence of blood in stools, or the child has convulsions. It is important to advise the mother or caregiver to administer other fluids such as rice kanji, buttermilk and coconut water at home, to continue breastfeeding during the diarrheal episode and start normal feeding once the child is rehydrated, to return immediately if there is decreased urine output, abdominal distension, drowsiness and poor oral intake with vomiting, and to follow up in 5 days if the child is not improving. Let us now move on to another common cause of under 5 mortality, namely pneumonia. Pneumonia accounts for 15% of all deaths of children under 5 years of age. It is caused by a number of infectious agents including viruses, bacteria and fungi. The respiratory syncytial virus, Streptococcus pneumoniae and Haemophilus influenzae are the leading causes of childhood pneumonia. Most healthy children can fight the infection with their natural defenses. However, children whose immune systems are compromised due to malnutrition, undernourishment, or infants who are not exclusively breastfed are at a higher risk of developing pneumonia. The treatment of adult pneumonia is discussed in the module on respiratory diseases. Let us look at some practical considerations in the treatment of pneumonia with the help of a case scenario. A 3-year-old male child Ravi is brought to your clinic by his mother with complaints of cough, breathlessness and fever. The child is taking food and liquids orally. On examination, his pulse is 120 per minute, the respiratory rate is 64 per minute and the temperature is 101 degrees Fahrenheit. There are decreased breath sounds in the lower part of the right lung with few crepitations. You diagnose pneumonia based on clinical findings. As a treating physician, what prescription will you write for the child? You will write the following: syrup amoxicillin 250 mg per 5 ml, 3 ml to be administered thrice daily for 7 days. Syrup paracetamol 120 mg per 5 ml, 5 ml to be administered as and when fever occurs with a minimum gap of 4 hours between 2 doses, up to a maximum of 4 doses in 24 hours. The following aspects need to be kept in mind while treating pneumonia in children. Bronchiolitis, bronchopneumonia, lobar pneumonia and empyema are common LRTIs in children. This triad of symptoms of fever, cough and breathlessness indicates pneumonia in children. Respiratory rate greater than 50 in infants and greater than 40 in children over 12 months of age suggests pneumonia. Chest X-ray confirms the diagnosis of pneumonia. Community acquired bacterial pneumonias need appropriate antimicrobial therapy with amoxicillin or amoxicillin clavulanate. Third generation cephalosporin should be used in select cases of moderate to severe pneumonia, and zinc and vitamin A supplementation should be given as adjunct therapy. All children suspected to have severe pneumonia should be referred to hospital as it can be life-threatening. Severe pneumonia is indicated by signs such as chest indrawing, stridor, or any general danger signs such as altered consciousness, refusal to drink or feed, hypoxemia or grunting. These children require oxygen therapy and treatment with intravenous fluids, antibiotics and antipyretics. Having studied 2 common illnesses in children, let us now look at the approach to the treatment of fever, which is one of the commonest symptoms of illness in children. Fever is defined as a rise of body temperature above the normal for age and diurnal variation, usually greater than 38 degrees Celsius. Fever may present with or without localizing signs, which should be elicited carefully. In newborns, fever should be interpreted with caution as their temperature is often unstable. While fever is merely an indicator of underlying illness, it may itself lead to problems, for example, febrile seizures, dehydration and discomfort. Here is a case of a child with fever. A 2-year-old girl, Priya, is brought to your clinic by her mother with complaints of high fever for the last 12 hours along with runny nose. The worried mother also informs you that 2 hours back she had developed altered behavior and abnormal movements of limbs for about 5 minutes, which resolved on its own. On examination, the child is fully conscious and active with body temperature of 38.5 degrees Celsius and reduced oral intake. She has no breathlessness, rash or urinary complaint except for mild cough. As a treating physician, what prescription will you write for Priya? You will write the following. Syrup paracetamol 120 mg per 5 ml, 5 ml as required, may be repeated after 4 to 6 hours, up to a maximum of 4 doses in 24 hours. Tepid water sponging in case of high fever. Continue feeding and give plenty of oral fluids. Report if the fever continues beyond 3 days or the seizures recur or any warning sign develops. The following aspects need to be kept in mind while treating fever in children. Fever of short duration, less than 24 hours, is common in toddlers and is usually due to a viral illness. Presence of runny nose supports the possibility of acute respiratory infection of viral etiology, which is self-limiting. Presence of transient altered sensorium and abnormal movements without persisting neurological symptoms suggest febrile seizures. Antibiotics are not necessary for the treatment of acute duration fevers with suspected viral etiology. Prescribe empirical antibiotics only if there are localizing signs suggestive of possible bacterial etiology, there are risk factors for occult bacteremia, and the child has an immunosuppressive illness. However, symptomatic treatment of fever is essential to prevent recurrence of febrile seizures. In addition, supportive measures are required to maintain nutrition and hydration till spontaneous recovery. Paracetamol 10 to 15 mg per kg is the drug of choice for the symptomatic treatment of fever in children. Advise tepid water sponging to bring down the body temperature in case of high fever. Encourage the use of oral fluids and feeding as fever leads to dehydration. Avoid drugs like ibuprofen, which can lead to GI bleeding and renal failure, and nimesulide, which is banned in the pediatric age group. Counsel the mother about possibility of recurrence of febrile seizures and its prevention by symptomatic treatment of fever. And finally, refer to a hospital if danger signs or symptoms such as rash, rigors, tachypnea or decreased urine output are present. You have learned the fundamentals of prescribing in an earlier module. However, pediatric prescribing is much more complicated as children are not small adults. Drug therapy in children differs from that in adults as the ability to metabolize drugs matures over time and their capacity to excrete drugs reaches adult levels by late infancy. A careful attention to the principles of clinical pharmacology not only improves the efficacy of pediatric prescribing but also decreases its costs and risks. Some principles to be followed by prescribing for children are: prescribe drugs only when necessary as children have intrinsic recuperative capacities. Before dosing, confirm details like age, weight and surface area. Prescribe appropriate formulations, for example, drops for neonates, liquid preparations or dispersible tablets for infants and young children, as medication adherence in children is highly dependent on the drug's taste, appearance and ease of administration. Explain the nature of the disease, likely benefits to be obtained from the therapy as well as adverse effects to parents or caregivers as they often manipulate medicines to aid adherence. Give clear written instructions including the need to complete a given course even if the child appears to be asymptomatic. Direct parents to discard all remaining doses so as to protect the child from improper medication at a later date, and carefully monitor the child's response to therapy. Here are some of the important references that have been used while designing this module. I would like to acknowledge the contribution of all the members of the RUMC committee at the SGS Medical College and KEM Hospital. Thank you for watching this video. I hope you are now ready to attempt the MCQs. Please access the MCQs in the assignment section and submit the answers. Please also complete the prescription evaluation as per the tutorial, which I hope you have already seen. Thank you and happy learning.